everyone, let's find out in this clip today if SGLT2 inhibitors are truly leaders in HFrEF management. Heart failure is a progressive disease associated with high mortality and readmission, with a 10% mortality in 30 days, 20% in 1 year, and a 50% readmission in 6 months. Diabetes increases the risk of heart failure by 2 to 5-fold, with a 60 to 80% increase in cardiovascular and all-cause death. Despite improvement in management through a guidelines-directed medical therapy, heart failure is not optimally treated in practice and mortality remains high. Should SGLT2 inhibitors be used in heart failure with reduced ejection fraction in patients with or without type 2 diabetes? Two such trials, the HFrEF and HFrEF, were recently published randomized controlled phase 3 studies that aim to establish a foothold for SGLT2 in HFrEF management, regardless of the presence of diabetes. Both studies included patients with EF less than 40% and NYHA class 2 to 4, comparing either dapagliflozin or empagliflozin against placebo. Both studies met their primary composite endpoint and achieved about a 25% reduction in cardiovascular death and worsening heart failure. This was mainly driven by a 30% reduction in heart failure hospitalization compared to placebo. Renal protective effects were also observed. A benefit for cardiovascular death was noted, although neither studies were powered for death. Of note, over 70% of patients in both studies had EF less than 30% and NYHA class 2. This group of patients had a better outcome with SGLT2 over placebo, likely due to sample numbers and less disease severity. 50% of the recruited patients had prediabetes or no diabetes. However, there were no significant imbalances in the tolerability or safety events between heart failure patients with and without diabetes. Adverse effects were typical of other heart failure medications such as hyperkalemia and hypotension. In about 30% of patients with prediabetes, SGLT2 did not demonstrate a significant prevention of new onset diabetes. Reduction in heart failure hospitalization is observed within 1 month of initiating SGLT2. While it is tempting to initiate SGLT2 upon diagnosis of chronic HFrEF, both studies initiated SGLT2 at least 2 months after the first diagnosis of chronic HF, 3 months from a major cardiovascular event, and at least 1 to 4 weeks later after a recent ADHF event, or when diuretic titration has stabilized. This allows time to clinical stability to minimize the risk of euglycemic diabetic ketoacidosis, commonly associated with the use of SGLT2 in acute stressful situations. It also creates a window of opportunity for the optimization of guideline-directed medical therapy first, especially in the absence of superiority studies of SGLT2 over current heart failure treatment. Despite positive outcomes in HFrEF and HFrEF, SGLT2 have not presented evidences stronger than other heart failure treatments in terms of cardiovascular death or reduction in heart failure hospitalization to consider it the leader in HFrEF management. So this is our take on the role of SGLT2 inhibitors in HFrEF. Are they then truly leaders in HFrEF management?